This is Jerry Hesch of the Hesch Institute, and we are looking at an x-ray of Cindy's pelvis. I'm pleased that we're not getting her last name shown here, so we're able to protect her privacy. When I went over the x-rays with her, I pointed out what looked like a shift at the pubic joint, and it looked like an increased width. When I glanced at her x-rays, I told her it looks like I'm glancing at the inside of the pubic joint, like your pubic joint might be lying very low and the angle captures the inside of it. Might not be true, might be the top of it. There is no way of knowing. So there's that image, and we're going to close him. And there's a consistency. There's 3 different AP images, and each one shows similarity, but the very last one shows a little bit more. Let's see, I've got to close him out. And this one you can see the alteration of the angle of the hip, called a frog's view, where they abducted a bit, and this shows a distinct, I think, an increase in the lower width of that pubic joint. So on this basis, I made the comment that I believe that there was a shift in the pubic joint, and we're going to demonstrate on her pelvis what we find in the clinic. So in the clinic, I'm using a crude tool because that's all we have. No one has invented anything any better than what I'm using. And all of this data is correlational. If we wanted absolute proof, we'd get a 3T CT scan with 3D reconstruction. We don't have access to such. This is not a research clinic. So we're doing the best we can, and we can get all kinds of critique for it, but you have to start somewhere.
Absolutely.
And what you do is you gather some objective data as best you can. You do the intervention, and then you find out if in your measurement tools if there's any difference, and in the client's presentation. You've been spending lots of money and going to lots of places and traveling. You've gone to Canada, you've gone out of state and stayed somewhere 6 weeks, yada yada yada. So in a client such as yourself, I think that investing 3 visits of 2 hours each in an attempt to wrap this up in a meaningful manner and taking the time to make these crude measurements, I think there's a value. And I sound a little defensive, and I'm not speaking to you.
Yeah.
My defensive tone is not directed at you. Okay?
We appreciate your thoroughness.
It's so easy to criticize someone, you know, when you see them on the internet. It's anyone can criticize, but it takes someone willing to roll up their sleeves and do the work.
Absolutely.
And here I am, and I will roll up my sleeves right now. So with my crude measurement, I palpate the top of the pubic bone, and just like I stated, your pube joint is rather low lying, and it extends on down, and it is posterior in the plane of the ASISs. It is somewhat low lying. But here's the very top of it, and I can push into soft tissue and then push down on it. Okay? Doing that, I'm on each side, and now I palpate along the face, and it does look like the left face is posterior. And if I slide across, going from right to left, there's a distinct step into the fibrocartilage. Okay, and that fibrocartilage then follows the right pubic bone. So I do perceive a distinct step down. So what I'm going to do now is put one finger across above the pubic joint. I'm going to put a finger below that, and then I'm going to place this tool across, and the tape is approximately at the level of the midline. Okay, so this is one of those carpenter's tool, and just previously I felt where the obturator foramen was. So I know that we're still on bone up to the end of this tool. So I'm going to start pushing these little critters in. Okay. And they are deformable. That's only electrician's rubber tape. Okay, so I'm not constraining them with tape. Okay, and neuroforamina starts right about there. So I'm making sure that I get a couple of these at a time and indent as firmly as I can. Okay? So we look at them, and there is in fact a drop down, which you can also see. Here's the midline, here's the black tape. I'm going to take it off. You can see a distinct step down here. So that's what this measuring tool shows. It's congruent with my visual perception. You, Mark, as an occupational therapist, looked over, saw the same thing. So we all are perceiving the same thing, and the tool is congruent with our perceptions of asymmetry. Can I have you lie on your stomach, please?
Sure.
We find with that what another renowned SI expert found. Am I correct that they found the rotation in the sacrum?
Yeah,
Yes.
that way, yep.
Okay, so in Canada they found that, yes?
Yes.
And you also saw a neurologist who studied all the osteopathic manual therapy techniques and studies at Michigan State. Is that correct?
Yeah, he teaches.
Teaches
I'm not sure where he studied, but I know
Okay.
he teaches there.
I
Yep.
think that's right.
So he found a left sacral rotation on you, okay? I find the same thing along the entire length. It does appear such. But it doesn't matter how something it appears. If we take it a step deeper and check function, I'm going to check, does it move on the right? And if I take up the slack through that structure, I can induce motion. I don't get a sense of it's stuck. I don't get a sense of it moves too much. All I can tell you is it moves with this test. I come on to this side, and I'm isolating S1, 2, and 3 because that's where the joint is. I can't even take up the slack. I'm putting 30 pounds of force. I can't even take up slack. It's so stuck, I can't get motion. Now, when we come onto the ischial tuberosity, here's the very bottom of it. So I come onto the flat part of it, and I take up the slack, and I can create a little bit of give. I can see her foot move, so the force goes through the pelvis down the leg. On the left side, which is posterior, you'll note I cannot take up the slack. I cannot create motion that goes through the pelvis down the lower extremity. Visually, her left ischial tuberosity is posterior. Okay, but more importantly is the motion test, and that's what a spring test is. We can also test the ligaments. Whenever you have a rotation of the sacrum or a shift at the pubic joint, they often go together, there will be a distinct difference in the sacrospinous ligament. Sacrotuberous ligament is right here.
And
It's rock hard.
And I know on internal exam with Dr. Heller, it was
Yes.
the right sacrotuberous, correct, Mark? That was,
On fire.
I mean,
On fire.
just, yeah.
Okay, so the right one was very painful. All right, so I can spring the right sacrotuberous ligament. Feels like a ligament to me. This guy on the left feels like bone. Okay, and if I come just slightly above that to find the sacrospinous, there's sacrospinous. Sacrospinous is rock hard on the left side of your body. On the right side of your body, sacrospinous I can indent. Okay, so anyway, that's an interesting pattern, and I'm done. I'll stop filming here, and just to summarize it, I'll show the model here. What I'm suggesting is that in the pubic joint, the left pubic bone is shifted posterior and the fibrocartilage follows that pattern. There's a step down going from right to left. We can palpate it, we can see it visually, and that tool that measures depressions, it's a woodworker's tool, is congruent with that. Okay? In prone, the other end of that bone is the ischium. The flat part of the ischium is posterior on this side, does not spring anteriorly, whereas the right side does. And the ligaments that connect sacrospinous and sacrotuberous, which would be taut if that sacrum is rotated left, are in fact very tight. So this journey of you trying to get relief goes back 5 years?
2 years.
2 years.
Thank
2
goodness
years.
not 5.
Yeah.
Okay, all right. Okay, there was a previous ankle injury or something 5 years ago.
2 years ago. Yeah,
Okay, so
2.5.
2
Yep.
years.
Yep.
2 years you've been chasing relief.
Yeah.
Yeah.
Okay, so anyway, that summarizes, and the sacrum appears to be rotated, which the left side is posterior and prone. Can't spring it, but can spring motion on the right. So we will treat it. We'll do a post-treatment film. Thank you very much.